for me? Um, I have a little bit of a different take on what we're going to talk about today because they asked me to speak on engaging primary care providers. So, myself, I brought a couple of my teammates with me today, but we're from King's Daughters in Ashland. And as my bio specified, I was born and raised in Ashland. I'm from Eastern Kentucky. When I went off for education, the goal was always to be a doctor, be a primary care physician, and come back and educate my community. So my focus has been prevention. In a lot of my work groups that I do, that's primary prevention and keeping our communities healthy has been kind of at the forefront of my medical career. Dr. Stack and Clotis both talked about how prevention is the key to winning this battle for diabetes, and I fully believe that. The collaborative that we were asked to join this year, that's been the focus. It's finding out our 1 in 3 adults that have prediabetes. We need to recognize it, we need to document it, and then we need to do something to prevent diabetes. I think that's how we win this battle. Dr. Stack mentioned that in one generation, 17 years, that we're doubling our diabetes rate, and that's just not acceptable. And I don't know that we're going to fix that. I think we need to look at the younger populations, and we need to educate. And I feel like that's all I do in my clinic. I talk and I educate all day long, but I think that's what needs to happen. Metabolic syndrome, even before we have the breakdown of prediabetes into if you're less than 5.7, you don't have diabetes, 5.7 to 6.4. Prediabetes, 5.6 and above is diabetes. For 13 years in my clinic, I have assessed every patient for metabolic syndrome. And what that is there's 5 risk factors. If you have 3 of the 5, you have a very increased risk of developing diabetes. So I've looked at, BMI, truncal obesity, high blood pressure, a fasting sugar, what's your cholesterol? And for patients, these are all modifiable, meaning that they have the power to change and become non-diabetic if they're pre-diabetic, or to reverse diabetes. Yes, as Clotis mentioned, that's not the initial goal, but if we can improve and make someone that's diabetic pre-diabetes, then we are going to improve their health. And some of these statistics we've already talked about, the 1 in 3 Americans that have pre-diabetes. This bottom statistic for the collaborative that we worked on, I think is very telling, that patients that completed this education collaborative were 58% less likely to develop diabetes, and that was even better than those that were on metformin. And so that's the work that we were doing. So this just explains the collaborative a little bit on who we were working with. So the Kentucky Diabetes Prevention and Control Program with the Department of Public Health, working with the CDC and the Prediabetes Learning Collaborative. And then we had regular meetings so that we could get information from the KDPP, from the Kentucky REC, and then KHI. It was a 12-month process, and it allows different organizations to share data. We presented the storyboard once every quarter with our data changes. And so just small tests of change to reach self-identified objectives. And those are objectives that we came up with, and we said, hey, we think that we can meet this goal, let's see. And then we tested. So performance improvement process, technical support provided through all those organizations that helped us with this. Clinical system changes, including identifying patients with prediabetes, and that was our number one goal. We wanted to see which of our patients had prediabetes. We wanted to utilize appropriate screenings and easy screenings that I could share them with my colleagues. Employing outreach initiatives increasing the number of referrals to our National Diabetes Prevention Program, and then looking at increasing our enrollment and attendance. So in this collaborative, we quickly surpassed the goals that we set at the beginning of the project. As mentioned in the bio, we did win a couple of prevention ponies, and then we were recognized last week at the RAC annual conference. And we opted to extend out beyond just the year. We're going to do another 6 months. And that being the reason that we chose to do that, at King's Daughters, we have 25 primary care locations. We have 70 physician APPs, and we want to get our work out to all of those clinics. And so we want this to be sustainable. So let me take you through our collaboration journey. This is my office, Flatwoods Medical Specialties. There are several people on the team that worked on this. Myself, I have one nurse practitioner in my office, Shane Bennett. Kim Bass, I'm going to have you raise your hand, Kim. Kim is our certified diabetes educator. She's also a licensed educator. Tammy Denton. Our admin team and technical team, Lisa Ashley, she's my dyad partner. I'm the physician lead and she's the admin lead. Jen Sword is our data analyst and she helped me with all the Epic build for this. Julie Hall, she does our quality. So a little bit of the background, and these are things that we've all heard many times today, but we need to recognize this risk population, and then we need to do something to prevent them from developing diabetes, and that was the whole purpose of us becoming active in this collaborative, just allowing for cycles of change to achieve performance excellence as related to identifying them and then managing them, and then promoting positive lifestyle changes through education. We wanted to align with the Institute for Healthcare Improvement Triple Aim, which is enhanced patient experience, quality and satisfaction of care, improved health populations, and then reduce per capita costs. And we've seen that over and over. And a recurrent theme today is how expensive it is for us to sustain our worsening diabetics, and then the care and the hospital stays. And so that's where that prevention can play a huge role in improving outcome. So our early theory hypothesized that increased screening of prediabetes would result in increased capture of diagnosis and subsequent increase in our NDPP referral volumes. Target population to optimize gains in halting the progression to diabetes. Essentially, we wanted to catch these patients and prevent diabetes. I'm going to mention a quick case study. So I was part of the first collaboration back in 2014. Kim worked on it at that time. And so I sent several patients that I don't remember at that point. I remember checking A1Cs, but I don't remember there being a set cutoff for prediabetes at that time. But their A1Cs, my 3 patients I sent, were A1Cs in the low 6s. And one patient in particular I still follow with today. And she agreed to go see Kim. They had a live weekly meeting for education for 16 weeks, and then it extended out to monthly. And they got a 3-ringed binder, one of the big white ones with all their educational information. And so she went. The goal at that time, and I still talk about these goals today, is a 5 to 7% weight reduction. And that 150 minutes or 30 minutes of cardiovascular exercise most days of the week. And so she said, I'm going to do this. She was in her 50s, a grandmother of 3 that she was raising. She wasn't exercising, she wasn't eating right, but she said, I can do this. I can lose 7% of my body weight. We gave her a goal. And so she did. She went to see Kim. She went through all the class, and she dropped her A1C. She was now non-diabetic. And she lost her weight. And then life happens, and I followed her along, and then we check it and kind of creeping up, and 2 years later it was back into the prediabetes range. She was back to 6, and She said, I'm going to go home. I still have that white binder, and I'm going to do this. I'm going to get it back out. I'm going to change my lifestyle, and I'm going to get, she said that she fell off the wagon. I'm going to get back on the wagon. And she did, and she's done that now a couple times. But the lifestyle changes are huge for our patients. I think that's what, I don't talk about diets ever in my clinic. It's all about lifestyle changes. It's like what you can do each day, and it's the education I give to my patient. What can you do to help your health each day? It's that walking 15 minutes. And one of my favorite quotes is, it's not about having time because we're all busy. It's about making the time for your health to get that 30 minutes of walking in. So, but this does work. I have the case study to prove it, that if we could just encourage our patients to be more proactive. So this is busy. This is just talking about what we did in this project. But essentially, we wanted to have 2 cohort groups, and we had an initial cohort group that started in March of 2023. And then we have another one that's going live next week. And a couple of the speakers talked about the Live Healthy Kentucky. And I think we're the first organization to go live with Live Healthy Kentucky starting next Monday. That may be wrong, but that's what I've heard. And if anybody needs to get a patient into that, we're happy to help. And Kim will be available at lunch if you need to talk about that. Our goal was that we wanted 33% of the patients that we referred for education to actually go through the education process. So increase prediabetes and diabetes screening. And we wanted to capture the diagnosis code. We mentioned earlier that a third of adults have prediabetes, but most don't know it. It's because we're not screening and checking for it. So we wanted to look for risk factors, and then we wanted to check an A1C. And then we wanted Epic to remind us to do that. And then we wanted quick ways for all of 80 of our primary care providers, and this will go to our specialty world later. We wanted quick ways for them to document it in the problem list and drop it into their assessment and plan, so that the patients, we knew who our prediabetes patients were, so that we can then create a prediabetes registry. Provider education. I'm the medical director of our primary care. We do a section. I run a section meeting for our primary care providers every quarter, and I give education on this just to encourage participation. The availability and accessibility of NDPP services. Through this collaborative, we were able to not only educate our patients within King's Daughters, but if we did not have a collaborative starting, then in the slides in a second, we'll talk about that we used Barnstable Brown and Pikeville, and we used their educators to educate our patients, because if I get somebody in the office and they're anxious to fix this, they want, what can we do? What can I do right now? I want to get them in education now. I don't want to wait 2 months for us to start a collaborative. So this allowed us to network throughout the state, which was very nice. And then health system change. That's where Jen came in for us to make our changes in our health maintenance, so that we were capturing these patients. And I mentioned already that we're hoping to have a prediabetes registry in the future. So our Plan, Do, Study, Act, our PDSA for this. So we wanted, first thing we did in the project is we wanted a way for all of our providers to be able to refer to Kim and her team. And so in Epic, we created a refer to prediabetes education button. Prior to that, we just referred to diabetes, but we really wanted to be very specific. This is a special cohort of patients, and they needed to be treated differently. And so we were able to do that with Jen and other IT help. The Epic Decision Support Tools, and I'm going to show you some screenshots of that in a second. The prompt for referral, the coordinating cohorts with Kentucky Diabetes Prevention and Control Program. We had a session that started in March and met each Monday. What I realized, I have a working class population of of patients, and they're not available for education 8 to 5 Monday through Friday, and so we were missing people, and I really needed a way for them to have education in the evenings and on the weekends, and whether that was web-based or now with the Live Healthy Kentucky. I love it because it's going to be at their pace and at their time, which will be very helpful. I think we'll get more participation that way. The referrals, I mentioned earlier that we had referrals to UK Barnstable Brown Diabetes Education Center and also to Pike County Health Department, which was very helpful. And then this asynchronous self-management education, I think that'll be very beneficial, like I mentioned, to the working class folks that they can't meet a set time. And so they'll be able to do it at their own pace. And we don't have data on that yet because that'll be ongoing. The other thing that I want our health organization to do in the future is we need to be recognizing these at-risk populations and screening them. And we looked at the beginning and just anybody whose fasting sugar was over 100 and random blood sugars over 200, that was a good place to start. In the future, I'd like our health maintenance to pick up those aged 45 and above, overweight, obese, a first-degree relative with a history of diabetes, which we know is a huge risk factor, high blood pressure, that physical inactive, so physically active less than 3 times per week. I love thinking of it that way because people really don't know how to they think if they move a little bit during their job that counts, but I like that way of really honing in on are you focused in your activity at least 3 times per week. And then our EPIC system currently does not pick up that history of gestational diabetes. Often they have their pregnancy when they lived in a different town or it's a different health organization. And so we need to add that to our MyChart. I don't know how many of you all use EPIC. Our MyChart, we're trying to expand that. Jen worked on, just last week we rolled out that patients are now going to be able to schedule their mammograms by MyChart, which is huge. And in the future, I'd like the CDC, they have a very nice risk tool for prediabetes. I'd like to roll that out to these at-risk people so they can fill that out before their visit with me, and they can say, hey, I'm concerned. I might be prediabetic, and I can say, glad you recognize that. Let's check your A1C. And I think that'll be very helpful to use that. So our screening flow sheet, patient presentation, we check their sugar, or I see in the computer that they've had a fasting sugar over 100 or a random over 200. We order the A1C, and then it takes you down one of two paths. Either you're non-diabetic, and we'll continue seeing you as regular, 5-7 to 6-4, you're pre-diabetic, and we can send you to our NDPP self-management program, or you're diabetic, and that sends you down a whole nother path that we already have in place. And so our PDSA cycles, the referral was a huge piece. The EPIC decision support tools that we're still working on, looking at glucose, looking at A1C findings, letting our EMR help us to find these patients. We wanted it really easy for our other physicians to document and refer. And then in the future, the registry build, we'd like to look at that. Health maintenance for screening opportunities. That Live Healthy Kentucky, I think, is going to be great. And then the use of MyChart and MyChart utilization for screening in the future. I think that's where we're going to go with our SDOH things too. I think that's kind of the wave of the future. And then, of course, sustainability. This is a quick screenshot. I thought there'd be more physicians in the room, so sorry if this is not applicable to what you do, but you can share it with physicians in your health system because I find this very, very easy. It'll flash, I'll get a message. If I have a patient, this patient, they flagged because they had a random sugar of 206. And so a random sugar of 206 in some definitions is diabetes, we know that's not always true. We need an A1C. And as you can see quickly, there's never been one done. So it will allow me quickly to order an A1C, a point of care if they're in the clinic. And then I wanted to have the diagnosis codes because if providers don't have to look that up, they may be more apt to order an A1C. And then this is the box. It'll tell me this patient, it flagged, this is our BPA for the A1C of 6. So any A1C in the system that's 5.7 to 6.4, and that patient does not have a diagnosis of prediabetes in the system, it will flag to tell me, hey, the A1C is 6. Do you want to refer to diabetes education? Do you want to add this on your problem list for the patient, and do you want to add it into your visit diagnosis so that we can capture that? So this is a BPA that we created as part of the project. And this is just showing our diagnosis capture from February to August of this year, and you see a steady rise. I will say, I have Shane and I, my nurse practitioner, and I both have young kids, so we vacation in the summer, and so there was a little bit of a lag period during the summer, but that's expected. But then we rebounded nicely in August. And then our data, the number of referrals from January to present or through August for NDPP was 83. Our internal providers provided 47 of those. We did get 36 from external sources. You can self-refer, and then we have done, Kim's done a great job of getting out with our team members. We have over 5,000 team members at King's Daughters. So she'll go to health fairs. I've spoken with our primary care physicians, and so they can refer. We have sent to community partners. And then our number of our patient population of focus that were diagnosed with prediabetes and referred, they agreed to go for the referral. 40 patients of those were referred, and 13 have actually gone through the education. And so a little less than our goal. We're 8 have, but our goal is 13. I think that will improve with the Live Healthy Kentucky that's starting next week. And this is referral growth. As you see, that little lull in June and in July, but then we've rebounded in August with paying attention to this. So our breakthrough and barriers, the momentum during the summer I mentioned with vacations, that was expected. We're excited about the Live Healthy Kentucky platform offering, and a couple things that we still need to work on. One is when we receive results, I'll order labs during my office visit. I may result those at night, or when a patient's not in front of me, it does not trigger the BPA. And so we've got to figure out what to do with those results when it's not a face-to-face encounter. The other, we did not set Epic to flag every time a sugar was over 100, because we don't have a good way in Epic to tag which are fasting sugars and which are not. And my colleagues would be very unhappy with me if they got a BPA for every fasting sugar over, or every sugar over 100, especially if it's in the afternoon and they just ate. And so we're still working on that. I mentioned already this external historical documentation of gestational diabetes. Those patients are at super high risk, and we're not capturing them right now unless you just ask the patient. And then the leverage with my chart, I think, is going to be huge. Spread is happening. We've already reached into South Point, which is in southern Ohio. We spread to southern Ohio and eastern Kentucky with King's Daughters. And then the offices on either side of me, the BPA will spread to them soon, with the goal that soon all 25 of our locations, the BPA is going to trigger for them. I'd like this to be a system-wide goal for King's Daughters, for us to recognize prediabetes and do a better job with this patient population. And then, this is all prevention. I just wanted to mention quickly that at King's Daughters, we do not ignore our current diabetics and those that are not well controlled. And so we monitor the uncontrolled diabetics on multiple quality payment programs. And this started with when MIPS was introduced. We have a physician scorecard, which I'll show you in a second, that it lists, we track system-wide what percentage of our patients attributed to a provider within our King's Daughters network that have an A1C greater than 9, which is poor control. And Jen also has created within that same Epic scorecard that physicians can look at readily and every day. You can click on, so I can click on a button and it will generate me a list of any of my patients who are outside of the 6-month range for A1Cs or whose A1C is greater than 9. And this is what our scorecard looks like. So these are even our specialty, our orthopedics, our surgeons, everybody has the same quality scorecard. We're very physician-led at King's Daughters, and I've been on the teams that have chosen which quality metrics go on the scorecard. We have a 5% holdback of salaries, and then you can make that back double if we perform on certain quality metrics, and diabetes is on there. So Jen just clipped quickly. So hemoglobin A1C poor control, so those patients that are greater than 9%, and this is an inverse measure. So break even is 35%, and that's something that we set as a break even, looking at prior years how we've done. Top box 1, which is you make your 5% plus 50, is 26%, and then top box 2, you kind of double your money. And I'm happy to say that in September for our A1C goal anyway, that everybody was doubling our money on hemoglobin A1C, because we spend a lot of time talking to our providers about getting those patients back into the clinic every month if their A1C is over 9, and really actively engaging our patients in their diabetes care. All right. Thank you guys for having us today.